please present his case of macular buckle with vitrectomy for myopic macular hole. Dr. Anshu is a leading vitreoretinal surgeon from Noida. He is a fellow from Shankar Netralaya, Chennai. He'll be presenting his case. Dr. Anshu, please proceed with your video.
Yeah, just a second. Can you hear me? Am I audible?
Yes, you are audible.
So I'll just share my screen 1 second. Is my screen visible right now?
No.
Not yet. Trying to share. Is it visible now?
It's visible now. It's visible now. You can get started, sir.
Right. So this was a case of a macular hole in a myopic individual. And to add to the complications, the patient had a posterior sapphiloma and a foveal detachment. And to add to that, it was the patient had retinitis pigmentosa. So we were dealing actually with a unique case which had retinitis pigmentosa along with macular hole and along with posterior sapphiloma of the high myope, the odds of which is very less to find such a case. So this was the presentation when a 60-year-old lady presented with diminution of vision of 2 months duration, nyctalopia since childhood. Vision was 2/60 on presentation. Clinically, she was high myope and now pseudophakic, had RP and a full thickness macular hole. OCT, as you can see on the screen, suggested a large staphyeloma, type 1 staphyeloma with full thickness macular hole, macular schisis, and a foveolar detachment. So at this time, we are dealing with multiple aims to achieve, multiple objectives to fight with. They are treating all these things together. I'll come to the video now, that how I proceeded with the case. Is the video?
It's visible, Dr. Anshu. Please go ahead.
Is it audible also?
Sorry?
No, sir, the video is
not
the
video
audible. No, sir.
Okay.
You will have to, when you are sharing, you will have to click share audio also.
Okay. Yes.
You can just give commentary so we can fit it in time.
All right.
Yeah.
I'll do that. So to start with, liberal 360-degree conjunctival opening was made. So basically a large conjunctival opening with large relaxing was made to accommodate the large buckle. And then followed by that, all 4 recti were tagged with cotton threads. Apart from recti, in this particular procedure, we had to find out the inferior oblique, and which was identified and tagged. This was followed by taking the Moran-Devon implant and passing the 4 mm wide band through the head of the Moran-Devon implant, and then the band was then passed through the inferior rectus, lateral rectus, and the medial rectus, and then the buckle was slipped under the lateral rectus and positioned well so that the head of the buckle is underneath the macula. The buckle is then secured under the lateral rectus by non-absorbable sutures, 5-0 sutures we use for buckles. And after securing the buckle at the right place, the bands are secured along the line of the muscle insertion in the superinasal as well as infranasal quadrants. After securing the buckle, then it was time to go in and with a 25 gauge regular vitrectomy procedure. We did a complete vitrectomy, and then
Please stop the
this was
buzzer,
followed
please.
by just forward it a bit, staining of the ILM and the peeling of the ILM. A flap of the ILM, since the hole was large in this case, a flap was ILM was used to plug the macular hole towards the end, and then the conjunctiva was closed carefully as the buccal element is large. So this is how the surgery was done. Post 6 weeks post surgery, the post-operative result was 6/12 vision. You can see a nice closure of the macular hole. You can see the flap of the ILM underneath. In fact, in the ultrasound imaging, you can see the head of the buccal so clearly under the macula. And this is the arm of the macular buccal, which you can see here. You can also see the buccal so nicely placed under the macula, and you can see the straight line here, which is depicting the end of the macular buccal. Thank you. Basically, I want to convey through this presentation that most of the time with such a picture, most of the retinal surgeons, they are demotivated to take up such cases because they think the prognosis is bad. But for the patient who has lost the peripheral vision and has subsequently lost the central vision, this matters a lot, and we should give a try with the procedure, which can help individually all the issues involved in such a case. Thank you.
I think that was a brilliant presentation, Dr. Anshu. Doing macular buccals is extremely difficult and challenging surgery. And you did excellent job and gave patient vision. Can I ask Dr. D.A.D. madam to please give comments?
Yeah, I would also like to congratulate Dr. Anshu. It is an extremely difficult case and very well managed. You are very right in conveying the message that yes, even in a situation which looks quite hopeless, it is definitely worthwhile giving a try, and the patient may benefit with some good visual outcome of such a situation. So I don't have any much personal experience with the macular buccal. I generally would like to do ILM peeling even in such a situation such as this. But maybe I will, I will give the question to others who have, experience in macular buccal. They can take the discussion forward.
Dr. Chetan, do you have any experience? Have you done surgeries with macular buccal?
I have done 2 cases, but generally when we have done the macular buccal, we have actually seen a large staphloma. And if we had, we didn't have a macular hole for that. We had a macular schisis. So we were actually treating the MTM, that is macular traction maculopathy, rather than the hole. In his case, I didn't see much myopic degeneration at the exact fovea, at that region. So just wanted to ask him whether could he have just done a routine myopic, routine vitrectomy with ILM peeling, and would that have helped instead of adding a macular buccal in his case? I'm not sure about the staphloma size.
If you look at the staphloma and if you look at the shortening which the retina had along with the macular hole, I would best expect a type 2 closure in such case. The hole may settle down, but there's definitely going to be a gap looking at the posterior staphloma. That is why I preferred to, support the staphylomatous area, so there is further shortening between the gap for the macular hole to close more, in a much better way.
Do you have some kind of an algorithm to say how much is the staphloma, the depth of the staphloma should be before you plan putting a buccal in these, adding a buccal to these cases? Suppose the staphloma is very shallow, suppose a shallow staphloma, then would you still prefer to put a buccal there? Like, for example, some of the staplomas are, suppose at the disc edge, it starts a steep curve. And I'm sure that would be, you would have seen such cases, and those cases definitely have severe macular traction. And I would agree with you on that. When you put a buccal, you are actually relieving that. Versus something which is a shallow staphloma, where even a routine vitrectomy with iron peeling would have helped. It's just I'm not done too many cases. I think Pradeep has done a lot of cases, but communications with him have revealed that he would look at the staphloma, the depth of staphloma, and then decide regarding putting a buckle along with the vitrectomy.
See, if the posterior curvature of the staphloma is right under your fovea, the highest point of the curvature, and it is looking a deep staphloma, looking like a deep staphloma, which you anticipate that the edges are not going to fall so well in that staphloma, then it's better to put a buckle.
Yeah, so I agree with you completely, and it seems to be a lot of the algorithms are not perfect, so it's a surgeon's experience and their decision making in that particular case.
Yeah, there is no particular study which describe how the depth of the staphloma where the macular buckle should be tried. But looking at this particular case, I felt this is the right place to attempt that.
Thank you, Anshu.
And ultimately, the patient did well.
Thank you, Dr. Anshu. That was a very brave and